This lecture will cover Module 10, specifically Chapter 13, Oncological Emergencies. Oncological emergencies are potentially life-threatening complications that happen from the cancer itself, like a tumor, or from treatment for the cancer that we give the patient. They are categorized by structural, metabolic, or hematological. And in this gray box here, you can see all of the different types. These are just some examples, and we are going to cover several of those. The first oncological emergency is a bowel obstruction. So this bowel obstruction would be the result of some kind of tumor on the outside of the intestine that kind of pushes on from the outside, or it could be a tumor that is growing actually inside of the intestine. And this can be partially blocked, or it could fully occlude the intestine, which would be obviously life-threatening. So the most common cancers that cause a bowel obstruction would be colon cancer, pancreatic cancer, and abdominal masses, specifically ovarian, liver, or prostate cancers. So signs and symptoms of a bowel obstruction will include reverse peristalsis. So what that means is more distal to the obstruction, you're going to have hypoactive bowel sounds, and more proximal to the bowel obstruction, you'll have hyperactive bowel sounds. So the patient can experience vomiting, abdominal distension, stools that are thin and ribbon-like. That is classic bowel obstruction manifestation. And then they can experience constipation and or diarrhea. So when you have a bowel obstruction, the best treatment is going to be surgery, but not all situations can be surgically corrected. So it really just depends. The patient will be NPO and they may require parenteral nutrition. So that is nutrition via the IV through intravenous access, and possibly peristaltic stimulants if it is not a fully occluded intestinal blockage. So what you want to remember as a nurse is to complete your focus GI assessment. You're going to assess their appetite, their bowel sounds, their bowel movements. Are they constipated? Do they have diarrhea? Do they have nausea, vomiting? Is their abdomen distended? Do they have pain or abdominal discomfort? The next emergency we'll discuss is hypercalcemia. So this is typically found with cancers that metastasize to the bone. So commonly breast cancer, lung, and kidney cancers metastasize to the bone, but it can also be related to paraneoplastic hormone production in certain lung and pancreatic cancers also. So we're talking about too much calcium in the blood. So signs and symptoms are going to depend on how severe it is and how quickly the hypercalcemia develops. So it can range from delirium, somnolence, muscle weakness, polyuria, bradycardia, nausea, constipation. So the treatment is going to be hydration. So we want to kind of dilute that calcium in the blood. We can give bisphosphonates to kind of decrease the bone from kind of breaking down the calcium into the blood. And then calcitonin, corticosteroids, and some other medications listed here. So with this one, you're going to assess that calcium blood level, phosphorus, because calcium and phosphorus have an inverse relationship. We're going to keep an eye on renal function because when you have a lot of calcium in the blood, it's going to eventually travel to those kidneys, and it can cause injury to those vessels. It can cause acute kidney injury, and it can eventually lead to renal failure. So we want to keep an eye on the renal function and, of course, our assessment, those general signs and symptoms of hypercalcemia. The next oncological emergency is leukostasis. So leukostasis is referring to the white blood cells, and this is mostly found in patients with leukemia, which is cancer of our white blood cells, specifically acute myelocytic leukemia. So these patients have really, really high white blood cell counts, like 100,000 plus. And having too much of anything in the blood is going to cause the blood to become very viscous, very thick, very slow moving. It's going to get caught in places and start obstructing vessels. It can cause complete blockages and even the rupture of vessels. So if you see in this picture here, this blood bag has been put in a centrifuge, which causes the contents to separate. And on the left, that's what it should look like normally. And if you look at this little thin layer here, those are white blood cells. It's also called our buffy coat. On the right side, this is a patient that has leukostasis. Look at that huge layer of white blood cells. So you can imagine if that was inside of our body. So with all of this extra viscous blood, this is going to most commonly affect the kidney, lungs, and brain. Patients are going to experience multi-organ dysfunction, bleeding from organs, so organ hemorrhage, congestion. So the first treatment is going to be fluids. We're going to want to thin the blood because we have too much white blood cells in it. Emergency chemotherapy, because this is systemic and chemotherapy is going to go through our vessels. Leukapheresis and general supportive interventions. So your assessment as a nurse is going to be monitoring that white blood cell count. We're going to look for signs and symptoms in our physical assessment for occluded microcirculation. This can include blurred vision, headaches, TIAs, strokes, shortness of breath, poor peripheral perfusion, and decreased urine output because it could affect our kidneys. We also want to look for signs of bleeding. Okay, moving on to pericardial effusions and tamponade. So these are mostly found with cancers of the chest. So lung cancer, breast cancer, lymphoma, and any kind of cancer that has metastasized to the chest. So maybe it started in the liver and now it's metastasized to the chest. So signs and symptoms are going to be dyspnea, poor perfusion, and signs of progressive right heart failure. So what is pericardial effusion? So we have our pericardium, which is the outside sac of the heart, and it has become full of fluid. So as it becomes more full of fluid, it becomes restrictive to the heart, and it's going to lead to impaired cardiac output because the heart is just not going to be able to pump effectively, and that is cardiac tamponade. So the treatment for this is to get out that fluid immediately, either by a needle or by a catheter via a pericardiocentesis. A surgical placement of a pericardial window or shunt can be done. It really just depends on how stable the patient is and how much time they have to do the procedure. Fluid resuscitation should be given until the provider is able to perform one of these procedures, because the heart really isn't going to be able to pump, and we kind of need to support the circulatory system. So our assessment is going to include vital signs. That's going to be very important. Signs of shortness of breath, signs of poor perfusion, signs of heart failure like respiratory distress, fatigue, and edema. If the patient develops this, we're definitely going to expect a pericardiocentesis and administer IV fluids as ordered. Next is pleural effusion, which is similar to the previous slide, but now we're talking about the lungs. So pleural effusions is when you have fluid within that pleural space around the lung. It's not in the lung, it's in kind of like the sac around the lung. This is going to be common with tumors that are located also in the chest, like a breast cancer, lung tumors, leukemia, lymphoma, ovarian, pancreatic, and prostate cancer. So when you have fluid wrapped around the lung, similarly to when you have fluid wrapped around the heart, it's going to start to push in and place a lot of pressure on that lung. So you're going to have a hard time breathing. It's going to compress alveoli, and it's going to start to affect oxygenation. So signs and symptoms will be shortness of breath, increased work of breathing, diminished breath sounds, and because of that lack of oxygen, the patient can experience confusion, anxiety, and agitation. So the treatment for this is going to get that fluid out via thoracentesis, where they insert a needle into the lung. Usually it's done through the back, like this picture here, to drain the fluid, or catheter drainage. So a catheter can be placed in short or long term to get that fluid out. Your assessments are obviously going to be centered around the respiratory system. So we're going to assess for shortness of breath, the breath sounds, is the chest excursion equal bilaterally, and signs of hypoxemia. So you also want to see if the patient is getting better. So after this procedure is done where they remove the fluid, the patient should be getting better after that. Next is spinal cord compression, and this is when there's a tumor near the spinal cord and it begins to press on it. So signs and symptoms are going to depend on where the tumor is located, and we're going to see neurosymptoms, so numbness, tingling, weakness, and pain. So the treatment for this, the first treatment will likely be radiation, because we want to shrink it down to as small as possible before doing any type of surgical intervention. That would be the preferable choice. Laminectomy could possibly be an option, corticosteroids to decrease inflammation, and possibly a vertebroplasty or kyphoplasty. This really just depends on the patient and where it's located and the size. So for you as the nurse, we're assessing for back pain, weakness, numbness, tingling, if they have issues with walking, and loss of sensation. So if they're not able to distinguish hot or cold, we know that that spinal cord is affected. And depending on the level of compression, the patient may have issues with bowel or bladder continence. Next is superior vena cava syndrome, and this is where you have a tumor around the vena cava that starts to push on it, and then it starts to obstruct that blood flow. This is going to be most commonly found in chest tumors, lung cancer, and lymphoma. So we're going to have definitely some respiratory signs and symptoms, so like shortness of breath and some venous congestion. So since that blood is going to start getting backed up, you're going to have edema on the upper part of the body. You might have some visual disturbances, headache, and altered mental status if it starts to affect the brain. So you can see this picture here with this patient lying supine flat on their back, that you can see that there's a color change. It's definitely flushed, congested with blood. So what happens is there's this tumor that's pushing against the vena cava. So the vena cava is where the blood returns from the body to go back to the heart. So if you look at this picture here, the picture on the left is when this patient wakes up. So you can see the face is a bit more puffy, it's full of fluid. And then the second picture is with the patient upright, like high Fowler's for several hours, and the blood is allowed to kind of drain down. So it's affecting perfusion. So your assessment for these types of patients is going to be looking out for our ABCs. So shortness of breath, you're going to look for edema, especially on the upper half of the body, the neck, face, eyes, and it's going to be most severe in the morning, just like this picture. Later, there's going to be signs of poor perfusion and decreased cardiac output, so the patient might become confused, might be cyanotic, low blood pressure, and tachycardic. Next oncological emergency is SIADH, syndrome of inappropriate antidiuretic hormone. So this is commonly found with patients who have primary or metastatic brain or lung cancer. And with this hormone, antidiuretic hormone, it's going to cause, if you have too much of it, it's going to cause you to retain fluid, and that is the problem. So SIADH signs and symptoms are going to be related to fluid overload and hyponatremia, and that's because the blood becomes very dilute, so you have dilutional hyponatremia, low sodium. This can lead to changes in mental status or seizures. The fluid volume overload can lead to pleural effusions, so fluid around the lungs, or edema. It can also affect electrolytes and your hematocrit because of that dilution, too much fluid retention. Hypertension occurs even if your SIADH is not that bad, but it becomes worse, of course, as you become more fluid overloaded. So treatment is going to be fluid restriction. So if they're retaining fluid, we don't want them to take in more fluid. And if that's not enough, then we might be able to give hypertonic saline. So that is usually just temporary on a short-term basis. And chronic SIADH, they could be given a lithium carbonate or dimeclocycline. There's also other medications. Vaptins are vasopressin receptor antagonists, and that could help. It just really depends on the clinical presentation of the patient. So for you, your assessment is going to be looking at fluid status. So you're looking at signs and symptoms of fluid overload, like that high blood pressure, so our vital signs. Hyponatremia, you're looking at labs. And then our neuro checks, confusion, seizures, and coma. We want to restrict fluids and then give whatever medications the provider has ordered. The next oncological emergency is tracheal bronchial obstruction. So this is when there's a tumor pressing down on our airways. This is most commonly found in patients who have lymphoma, lung cancer, and any kind of centrally located metastatic lung lesions. So you can imagine if you have a tumor pressing down on your airway, you are going to have those respiratory signs and symptoms such as stridor with shortness of breath, may experience wheezing if the bronchi are involved. If it becomes very severe or it's a late stage obstruction, you might even have absent breath sounds when there's no air actually passing through. And then patients are going to be more hypoxic than hypercarbic, which means their O2 will be low versus their carbon dioxide being really high. So the treatment could be bronchodilators, corticosteroids. They may need a stent placed to open up that airway, laser therapy, cryotherapy. It really just depends on the situation and how we can shrink that tumor down. As you know, that is our airway, so it's a very delicate area. So this will be, of course, the provider deciding what the best plan of care is. And then definitive anti-neoplastic treatment will be initiated simultaneously, so chemotherapy. Assessment for you is going to be signs of respiratory distress, stridor, wheezing, and hypoxemia. And our final oncological emergency that we'll be discussing is tumor lysis syndrome. So tumor lysis syndrome is when rapid cell lysis occurs. So many cells are becoming injured or opening up and they rupture. And this could be related to a rapidly proliferative disease, so like the cancer itself, or the neoplastic or the anti-neoplastic treatment. So like the therapy that we're doing to kill those cells is causing lysis of a lot of cells. And when this happens, there are so many cells that are lysing that can't be cleared. They accumulate, and all of their contents, when they spill out, cause major electrolyte imbalance and or renal dysfunction. Okay, so tumor lysis syndrome is most commonly found in patients with rapidly proliferative tumors like leukemia, lymphoma, and therapy-sensitive tumors that respond quickly to treatment. So maybe you have this really great medication we're giving and it destroys the cancer cells really well, really quickly, but then it kind of works against us because all of those cells are spilling out the contents and then it causes these imbalances. So signs and symptoms are going to be related to those electrolyte imbalances and how severe it is and how the kidneys are affected. So most common is going to be hypocalcemia and hyperkalemia. So when you think of tumor lysis syndrome, you want to think of hypocalcemia and hyperkalemia. So low calcium and high potassium. Patients will often go into acidosis as this becomes more and more severe, and we can see heart block on the cardiac monitor and tachypnea. Patients also experience hyperphosphatemia. Remember, phosphorus and calcium have an inverse relationship, and this can lead to renal dysfunction. So we are going to monitor kidney function. Treatment for this is going to be large volume IV fluid and diuretics. We want to dilute the blood and we want to try to excrete some of those things that shouldn't be swimming around in the blood. Hyperuricemia is treated with rasburicase if the uric acid is already elevated, and alpurinol is given to prevent hyperuricemia, similar to gout. So electrolyte abnormalities are managed supportively, meaning we're going to check those labs and then treat it accordingly. If renal failure occurs, they might need hemodialysis, followed by CRRT. Just depends on how the patient is doing and how stable they are. So your assessment, we are going to be looking out for those most common imbalances that we expect from tumor lysis syndrome, which is the low calcium, high potassium, and high phosphorus. So with hypocalcemia, we can see paresthesias, which is like the numbing and tingling, neuromuscular irritability, signs and symptoms of renal dysfunction. So again, we're monitoring the BUN and creatinine. We're also going to monitor urine output, ECG changes. So these patients should be on a heart monitor, and we could expect to see a heart block or peak T waves. And then we're going to keep an eye on their blood pressure vital signs because they're at risk for hypotension. And that concludes oncological emergencies.